Hi, so we're going to make a start to today's webinar, the ePrescribing Masterclass. Thank you for joining us. I'm Amna and I'm joined with my colleague Hoyan, and we're the clinical fellows at NHS England. We've got three really great presentations for you today, but just to go a bit about the background of the monthly webinars, they're for organisations to share their learning and experiences of digital transformation to help others support sort of fast following, and the aim is to break down the silo working, create a community and enable other trusts to learn from each other. So just a bit about the housekeeping. So for all of you that are watching, there's a questions box. So as the presenters are doing their presentation, please put any questions that you have in that in the box. Then they'll be answered hopefully either at the end of the presentation or after the masterclass itself. And you will get a certificate of attendance after this webinar has finished. And if there's a topic that you'd like to present on, please do get in touch with Sarah and she will be able to pass this information on to myself and Hoyan to look at future speakers or presentations that you're interested in. So I will now pass over to Hoyan to introduce our first speaker today.
Hi everybody, I'm Hoyan. Just to let you know, we did have to do a little rejiggle of our agenda for today. So we're going to start with Sandeep. Hi Sandeep, welcome to the masterclass. Sandeep has been a pharmacist for the last 12 years working in digital healthcare. He's passionate about using digital technologies to advance healthcare delivery, improve patient safety, and gain efficiencies across the system. He started his career working in the NHS implementing digital systems, and then after that he's moved on into the private sector to extend the scope and reach in healthcare. Sandeep has worked internationally across Europe and the Middle East, including a 4-year stint in Qatar, developing digital healthcare systems ahead of the last FIFA World Cup. I am interested to learn about what you're going to present about burnout in pharmacy, a digital system to cure oracles. I'll just hand it over to you, Dan.
Thank you so much, and thank you all for joining today. So, yeah, I think the introduction kind of gives an overview of where I've been in my career so far. But I think what it doesn't explain is that as part of my career, I've kind of worked across multiple healthcare systems, come across multiple digital solutions, and experienced kind of first-hand stresses within pharmacy. And as part of my roles within the supplier space, I'm lucky enough to work closely with multiple pharmacy professionals on a day-to-day basis. And really over the last few years, it's become apparent to me that there's really an increasing reliance on technology, but often a lack of understanding around the impact of technology on the staff force itself. So I really wanted to explore this topic a little bit further and in a bit more detail. And so hopefully today I'll take you on a bit of a journey through my research and my findings in this particular area. Next slide, please. So what is burnout? So I would describe burnout as something which is isn't really an instant consequence of stress. It's almost that cycle of continuing to kind of plug away until you get to a point where you're so stressed that you end up burnt out. It's a little bit like these frogs. So they will have entered cold water at a point in time, and without realizing it, before they've kind of even had a chance to process it, they're completely burnt out, or in this case, become a meal. So I think it's something which can creep up on you and ultimately result in a person feeling completely hopeless and completely stressed out and unable to function in their normal capacity. So it's definitely something to be mindful of as not necessarily an instant thing that you can recognize, and that requires constant inward reflection as to how you're feeling in the workplace and how stress is affecting you on a day-to-day basis. Next slide, please. So the coining of the term burnout was done by a psychologist called Herbert Freudenberger, who in 1974 described it as a particularly person to caring professionals. So for more than 40 years later, burnout is still kind of conceptualized as uniquely affecting those in emotionally demanding roles. And during the 1960s and 70s, there was a lot of work done, particularly in the air traffic control industry, which I'm sure many of you are aware, has multiple parallels with the way in which we deal with healthcare through, risk analysis and management of risk in particular, but also in terms of how healthcare is arranged and organized and run. So air traffic controllers reported poor training environments, inadequate equipment, rapidly changing shift patterns, long shifts without breaks, fatigue, monotony due to automation, and challenges arising from human-machine interfaces. So and what we then started to see was a huge increase in air traffic with a small rise in the number of controllers. This pushed working conditions beyond what controllers considered to be safe. I guess to many of you, this probably sounds familiar in terms of if you were to line it with healthcare, increasing pressures, increasing numbers of patients, whilst not necessarily having that increase in the workforce or the tools around you to support that. So as I mentioned previously, burnout's the accumulation of stresses resulting in a variety of different consequences. And that could be from missing the occasional break to changing your life to accommodate work more. And within the pharmacy perspective, I think, there can be a buildup of different factors which result in an increasing level of stress. And ultimately, this can become debilitating to the individual, resulting in what we call burnout syndrome. So within pharmacy, that could be, a variety of different factors. It could be underappreciation for the type of work that you're doing, feeling overworked with the increase in pressures around the number of patients that you're expected to see on a day-to-day basis, for example. Going on and actually revising your internal values, living to work instead of working to live. And then ultimately, denial that there is a problem, not recognizing the issues and the problems, and resulting obviously in harmful mental health narratives as well. And I think, these causes create their own issues. Ultimately, it leads to physical stress, changes in your behavior, feeling withdrawn from your support systems, becoming vulnerable to vices, and other alarming changes in behavior. It can lead to obviously mental stress, feeling cynical and disconnected, feeling like you're just a robot and you're just processing information on the day-to-day basis. And ultimately, one of the major consequences of burnout is absence, to the point where you may feel depressed, you may not feel like you want to come into work, and everything feels hopeless and it's time to give up. And ultimately, that then in turn creates more pressure on the system itself. Absence leads to increased work on the rest of the team, and that vicious cycle can continue. There's a lot of contributors to what burnout to burnout, and I'm hopefully going to take you on a bit of a journey through what I've discovered over the last few weeks in this space. So next slide, please. I wanted to really focus on kind of the digital contribution to burnout, because I think it's something that's burnout and stress is something which is relatively well researched, but we often don't attribute it to different factors which could be contributory to the problem. So we talked about air traffic control, the monotony due to automation, the challenges arising from human-machine interfaces being key factors in burnout amongst staff. Well, one of the factors that's often overlooked when analysing the causes of burnout are digital systems. We often attribute these systems to efficiency, to improvement in our working lives. However, this isn't always the case. Having worked in and with pharmacy for many years, it was clear to me that IT systems can be more than just a frustration for pharmacy staff, as we often hear. And I really wanted to explore this further with two goals in mind. One, increasing the amount of research in this particular area, and two, also to understand how systems can be improved to alleviate these frustrations and stresses. So a few weeks back, me, along with one of my colleagues, published a survey to understand the scale of the problem, and I'm going to take you through the results now. Some of you who will have attended Clinical Pharmacy Congress may have already seen aspects of this presentation already, so hopefully it just kind of reinforces the message. So next slide, please. So the survey itself was published via LinkedIn. It was fully anonymized, and in total, we ran the survey for just a short period of time of about a week and a half, and we had 81 respondents in total. That included 49 pharmacists, 26 pharmacy technicians, and we asked a range of questions to try and get to the bottom of the problem in terms of whether there is actually an issue with regards to digital and its relation to stresses within the pharmacy workspace. So looking at kind of the demographics of the respondents, initially we looked at the hospital type. So the majority of respondents were, of course, from the acute sector, which was as expected, given it makes up the majority of the hospital pharmacy workforce. And then the next largest group was from the mental health sector, which again, I think makes a lot of sense given the focus of the actual survey itself being around burnout and the effects on mental and physical health. We received really good representation from different age demographics, with nearly 50% of respondents from the 35 to 50 age category, but also good representation from most other groups also. And there was a wide range of professional experience in our respondents also. So with, a relatively even distribution between the number of years of experience, the major one being 20+ years. So ultimately the individuals who have kind of seen all of the change through pharmacy over the years, and probably been impacted by that change and a shift in working processes over that 20-year period. Next slide, please. Interestingly, the state of stress within hospital pharmacy was actually something which surprised me, to be honest, but also at the same time it didn't surprise me. I think it was clear that there was a huge degree of stress within the hospital pharmacy workforce. I think that was kind of already clear to me, but it was just the sheer scale of how many people reported they were extremely stressed, which really surprised me. So our categories really were not stressed. So, and we described that within the survey as someone who's able to operate at close to full capacity. Slightly stressed, which is someone who's taking regular breaks but feeling frustrated. Moderately stressed, someone who's missing occasional breaks and feeling tired. And extremely stressed, someone who's regularly missing breaks, feeling overwhelmed, unable to focus, and anxious in task completion. And what we found was over 66% of respondents reported being at least moderately stressed. This in itself is alarming, and although the stress is not wholly attributed to IT, if there are some simple changes we can make in IT to help to alleviate this or reduce this number, then that can be a really, really big step forward for us. Next slide, please. So what are the IT-related causes of stress? We actually allowed the respondents to select more than one option from this list on the left-hand side of the chart. And as you can see, there was quite a range of responses, to be honest. So I'm going to cover the first four just for kind of time's sake, but just starting with the first one and most selected one: use of multiple systems to carry out your day-to-day work. And this really speaks to the fact that, particularly within pharmacy, where we're utilizing multiple systems on a day-to-day basis, whether that's your EPMA system, your pharmacy stock control system, your automated drug cabinets, your lab systems to understand what lab work is going on for that particular patient. You're constantly chopping and changing between systems to understand the full picture around the patient. And it's only, really with the advent of EPRs, which do everything in one place, that we're starting to see a shift in that. But even still, there is a huge problem related to the amount of different systems that you have to use on a day-to-day basis. Flow systems, I think probably all of us here and on this webinar will have complained at some point in time of a slow system within pharmacy or within healthcare in general. It's a real problem that plagues us, and but fortunately there's a lot we can do about it, and I'll come on to how we can kind of start to alleviate some of those issues around slow systems. The other piece was really around strain on the eyes. So starting to look at some of the physical stresses that come with utilizing IT systems. Going back 20 years ago, when we were using paper drug charts, there was, probably a lot less strain on the eyes, a lot less strain on individuals from a physical perspective. But we're using screens on a day-to-day basis as part of our working practices to deal with patients. So strain on the eyes is a real big problem, and I think the fact that it's coming in the top 3 of IT causes of stress within pharmacy is a really important factor to note. And then finally, too many clicks. I think this really speaks to the efficiency of navigating around systems, how difficult it can be sometimes, and how many different places you have to click to actually get to the item of information that you're looking for, or to carry out the task that you're looking to do within your system. So yeah, so some really interesting kind of points there. Obviously a few others there to consider also. Next slide, please. So there were 2 reasons for this next result, which is, can IT improvements reduce stress? I think, it's very clear that I think most respondents felt that changes to IT systems or improvements in IT systems could help to alleviate levels of stress within their day-to-day, within individuals' day-to-day working practices. And I think there's, as I said, I think there's two reasons for this. I think one, the sheer improvement, the basic improvement in IT systems has the potential to reduce stress by just introducing, alleviating the issues that were causing the stress in the first place. But I think the second piece is, can it go one step further by enhancing efficiency and thus improving output? So allowing you to actually, impact on your day a lot better with the use of technology, using the technology what it was actually designed to be used for in the first place, rather than kind of having to use workarounds, etc. So I do think there's two factors which kind of feed into this narrative around how IT can help to improve stress and how likely that would be. Next slide, please. We also allowed the use of kind of some narrative answers. So we allowed free text answers as part of the survey on one particular question, just to get a feel for what individuals are actually thinking in terms of, what are the challenges, what are the stresses, and how can those be improved. So these were 4 suggestions by individuals who responded to the survey. And I'm going to take you through kind of each one and just kind of talk to what that really relates to. So the first was more systems integrated instead of doing the same task in multiple systems. So this really talks to the concept of interoperability, getting systems to talk the same language as each other, preventing the individual user to have to go into multiple different systems to actually carry out their day-to-day work. Faster systems, reduced unnecessary clicks, stable, not crashing multiple times. I think this really talks to the reliability and the speed at which the system acts. I mean, ultimately on a day-to-day basis, we're looking after patients. We want to ensure that process is efficient and as stress-free as possible. And if we can start to impact on some of the slowness of systems, the efficiency of systems, then that would have a much bigger impact in terms of being able to get through our lists on a day-to-day basis. Better systems that talk to others with minimal switching between screens, I think kind of talks similarly to the first point around interoperability, but also around screen design. I think there's also a massive piece of work to be done around how we can actually make the navigation around systems a lot more efficient to enable users to get the best experience out of the system itself. And then finally, less freezing, loading of systems. Again, kind of talking to that reliability. What is it that we can do to actually make systems more reliable and reduce the stresses that comes with unreliability of systems as well? Next slide, please. So as part of the research, it was all well and good kind of getting the results of it, but what was really important to me was that we started to devise a model around how we can actually start to impact on some of this stress causing IT issues. So what I came up with was a 4-pillar model of IT stress reduction, and that really focused on 4 key areas. So workflow optimization, interoperability, adoption of new technology, and user-centered science-based design. Again, using all of the feedback that we got through the survey, I was able to come up with these 4 pillars because I felt that these were the key ones which could result in a major impact on reducing pharmacy-related or digital-related stress within the pharmacy workplace. So taking each one at a time, workflow optimization. So a common factor which came out from the survey was the amount of workarounds that staff needed to follow. And by nature, a workaround comes with risk, and with risk comes stress. So it's important to, I believe, iteratively update both workflows and system design to make sure that they're in sync with each other, and to make sure that you're getting the best out of a system with the workflows that you have in place. This obviously also has benefits for staff stress in that staff are kept informed and consulted on the changes being made. I think it's really important that that is a key factor in any design process. It's much less stressful when you understand the reasons why certain changes have taken place, rather than that change being imparted on you without necessarily your consent or your backing. So that was a key factor which kind of feeds into that workflow optimization piece also. Interoperability. So as our healthcare system increases in complexity and the number of systems utilized increases, it's increasingly important for solutions to adopt the latest standards, whether that's FHIR, PEPAL, GS1, whatever that may be. It's really important that system suppliers are adopting the latest standards to ensure that systems are able to talk to each other, communicate, and exchange information, because that is the world that we're living in now, where we have multiple systems and we need those systems to exchange information and data. So the easiest way to do that is if they're all talking the same language as each other. So it's important that those standards are adopted, and that also helps with suppliers being able to collaborate with each other to deliver the best for what the NHS and the wider healthcare sector needs. And ultimately, that is, ultimately putting a focus back on the patient, being able to provide a focused set of information around the particular patient themselves. And ultimately, this reduces the duplication of effort and often a reduction in the amount of interaction with technology as well. So reducing the amount of times you have to go to different systems to carry out your day-to-day tasks, which ultimately results in time being saved. And then finally, user-centered science-based design. So a quick, I think, we come across systems on a day-to-day basis which are very much designed either in a very old way, with old screens and old methods of working. I can't stress enough how important it is that we start to design systems with modern user interfaces to meet the needs of kind of this current generation. I think we're so used to pinching and zooming and swiping on our phones and the user interfaces that we have on those, that it's quite frustrating when you then come across a system which is grey and dull and boring and doesn't really kind of do the job for you, and means you have to click in different places for it. And finally, I think adoption of new technology, and this is really critical, making sure that we're adopting technology which introduces resilience and reduces the amount of crashing and downtimes that your systems have. So the key one there for me being cloud infrastructure, making sure that systems are built on the most robust infrastructure that you can possibly have, because that also introduces cybersecurity and safety as well. I think all of that has a big impact on stress itself. Last couple of slides. Next slide, please. I think there's a few things that suppliers can do better. I think primarily listening to customers and listening to feedback on the issues that they're experiencing. Involving the customer in the design journey, I think, is hugely important. Understanding the needs, developing pipelines for items which matter the most to customers, not just going out and developing pipelines for what suppliers think is needed, but actually taking that feedback and building it into your systems. And introducing more streamlined workflows is part of it. And ultimately avoiding digitizing of manual processes. So we don't just want to take what was on paper and digitize it, because that simply just does not work. We've had experience of that, and ultimately just leads to stress in the workplace as well, because systems aren't designed properly. So we do need to start to look at a more mature, more user-centered model of delivering digital solutions. Next slide, please. I think that's me done. Just one final bit, which is this research really is kind of the start of the journey. We really want to kind of take this forward, and I really want to take this forward. So I'll be writing a white paper, publishing the results. We're going to take it forward with a 4th-year MPharm project later on this year to kind of expand the research cohort and understand it a bit better, and then ultimately develop some research around the 4 pillars model as well. Thank you so much.
Thank you, Sandeep. That was a really good presentation, and some of the IT-related stress causes really resonated with me. I found it quite worrying that more respondents in your survey actually said that they were extremely stressed compared to no stress. So I've got a couple of questions that were raised by our audience. Okay, if I send a couple of them your way now? Yeah?
Yeah, please,
okay.
yeah.
Yeah, so just to confirm, the survey that was sent out, was that a standardized questionnaire, or was that something that was created by yourself?
That was created by myself, yeah. It was based off of kind of, I've got a lot of peer feedback from other pharmacy technicians who I work with on a day-to-day basis. But yeah, it was a survey which I crafted based off of kind of my experience in the field and understanding of, some of the key factors which may cause stress. But also to understand it on a more general basis as well.
Yeah, okay, that's brilliant. And then I've got a question from Anna. Were you able to identify any type of system increase the level of stress? For example, would it be a pharmacy-related IT system or data management or your health record? Did you have any data on that?
Absolutely, yeah. So there's still a bit more analysis to be done, but on kind of the data that I have, the two kind of main system types which caused the most stress were EPMA systems and EPR systems, primarily because it was around finding the information in the right place at the right time and having access to that information to be able to do your day-to-day work. The other area, I guess really what I found was there were different stresses related to different types of systems. So one of the major stresses that I identified as part of the results was how pharmacy systems or pharmacy stock control systems were linked with poor user design and quite outdated user design. And that led to increased stress levels because although the systems were relatively easy to use, it just resulted in strain on the eyes and factors like that, which sometimes often not are taken for granted really. So yeah, absolutely. There's a little bit more work to be done to analyze the results a bit further, but I'll be publishing that in the white paper that I send out.
Okay, we'll be looking forward to that paper that you publish. Thank you very much. Just in the interest of time, I'm gonna stop here. Are you happy to answer any of the questions that hasn't been answered offline after the call?
Absolutely, yeah. If anyone wants to send any questions across, no problem at all. Thank you so much for your time.
Thank you very much, Sandeep. Okay. So I'm going to introduce the next speaker. Ajwa, are you here? Hi, hello. Yeah. So a warm welcome to Ajwa. She is the digital education lead at St. Francis Hospice. She has experience in healthcare leadership, education, and program management, and she's passionate about advancing the EDI agenda. Today, she's here as a Shuri Network Steering Group member, and will talk to us about the Shuri Network and the opportunity this network can bring us. Ajwa, I hope you've recovered from your exciting trip yesterday to the House of Commons. Was for a celebration of an anniversary, wasn't it?
Yeah, we were celebrating our 5th birthday, so it's technically in July, but we've had it a bit earlier, and we went to the House of Commons, and it was an amazing day. So yes, I am a little bit tired, but yeah, no, it was good. Thank you for asking, and thank you for asking me here to talk about our fellowships, which also launched yesterday.
Okay,
thank you.
I'll hand over to you.
Lovely, thank you. So thank you to Hojan for inviting me to talk to you all about the Shuri Network and the fellowship. If we could go on to the next slide, please. Thank you. So the Shuri Network is the first network specifically designed to support women of colour working in digital health and data. And this picture here is actually the launch of us at summer school by our co-founder, Dr. Shira Chok. She's there holding the microphone. And as you can kind of see in the audience, it isn't that diverse. And partly why Shira started the network was because often she was working in lots of different digital health spaces where she just really wasn't seeing people that looked like her. And so the launch came at this event, and actually for most of the people in that audience, that was the first time they were actually seeing a fully diverse panel of women talking about digital and health. And really that is one of our missions, is that we as a network want to build a digital health workforce that really reflects the communities and the populations that we serve. And as part of that, there is a lot of work that we do around that. So if we could go into the next slide, please. Thank you. So as I've mentioned, yeah, we are also supported by NHS England, and really our work is about developing the skills and the confidence and the connections for women who are interested in developing in this field. It's about championing difference. It's about being able to increase safety and healthcare and kind of make systems and make tech work for everyone in our community. We are growing by the minute, and actually, although it says we've got over 2,500 members, actually I think it's closer to 3,000 now, and of course we are supported by many allies. Again, that's 300, but I think it's over that as well. And you know, a key thing for us is really about creating opportunities. So we funded over 100 different bursaries, and we've run 80 people through our digital leadership fellowship. and we are also award winners as well. So it's something that we're really proud of, and the work continues to grow. Next slide, please. So as I mentioned at the beginning, we were celebrating our 5th birthday yesterday, and as part of that, we were also launching our next fellowship, which is our cohort 4. So this particular fellowship is a digital fellowship that runs from September to May of next year. The fellowship is open, where predominantly when I started, I started on the first cohort. It was only for nurses, then it grew to nurses and midwives, and now it's open to all fields. So whether you are a clinician or you are working in data, it is open, and I'll go through the criteria for that as well. But in terms of the particular program that we offer, first and foremost, we offer one-to-one for every fellow that joins the program, one-to-one executive coaching sessions. And as somebody who's been through this program, it is second to none. It's something that is so unique in what we offer, and it's such a great way for people to really unpick their own digital journey and really think about what options may be available to them in the future. It helps build confidence, and actually we get to test that out across the time of the program, because often you are asked to kind of speak at different events and do different presentations. So it's a really great way to kind of develop those skills. This is fundamentally an education program as well. So throughout the fellowship, we have lots of opportunities for learning. We run different sessions around personal development, digital data, leadership, and it's tailored because we really will, once we get our cohort together, work with them to find out what the needs are and kind of use that as a way of kind of designing the content around it. What's great about the fellowship as well is that it's a really heavily based peer support community. You're in a space where you are really held. You are held by your group, you are held by all the people that work around it and through the program. And so this is, you know, for me, cohort 1, there are people that I'm still very friendly with now, and I lead on the alumni. So once you finish the program, there's a whole another program of work that we do to support you beyond the fellowship as well. And it's a great networking opportunity. For some people working in digital, they might be well connected, but actually you may be working somewhere where maybe those opportunities aren't quite available to you. So this is a great way of kind of meeting lots of different people in the space, all the different specialisms. I specialise in education and digital education. So again, building those kind of wider networks in that area. Next slide, please. So I'm not going to kind of read through the eligibility criteria. Everything is on the website here, but kind of key dates to kind of make you aware of is the 4th of June. So we launched yesterday. Applications are due to close on the 25th of June. What I would say is that if we do get a huge amount of interest, and I think we will, because we already have had quite a lot of interest for it, it may close earlier. So I would really encourage you, if this is something that you think appeals to you, do get your applications in. What we're looking for in our applications is people that have passion for digital. You don't necessarily have to be working in digital, but at least have digital as a key part of your role, or a way to be able to describe how you can see digital. And actually we're all using digital, so that should be easy to align. And the program is due to start in September. Next slide, please. So I've been very brief because I've got a 5-minute slot, so I was really conscious of that. If you do have any questions, please feel free to put them in the chat, or of course you can kind of reach out to us independently. But what I would say is, obviously, maybe people think I'm biased, but I do promise you this is an amazing opportunity. And what I would say, just for our allies on the call as well, is the fact that, you know, if you yourself can think of anybody that you could support through the fellowship, that would be amazing. We really value our allies, and you know, if anybody's interested in being a member in the Shuri Network, all the details are here. So thank you.
Thank you, Adjoa, for your presentation. Very concise about what Shuri Network is and how and how we can join, and what the fellowship is all about. Can you talk a bit more about the time commitment, because you did mention it's a part-time fellowship?
Yeah. It is. So in terms of the time commitment, we usually meet on a Friday. So there's usually a sort of educational session which runs for about an hour, and that usually goes sort of every other week. So it's usually bi-weekly sessions across that period of time. You are asked to do some reflections as well, but you can kind of work that around your own time. Your time with the coach, again, you organise that with your coach, so you can determine whether that's going to be, you know, before work, in the evening, or you know, during your working day. And again, I would really be encouraging people to kind of have those conversations with their manager about the support of the time to do it, because that really does help in being able to make sure that you're not under that pressure of kind of, you know, trying to fit it around all the other responsibilities that a lot of people have.
Absolutely, that's brilliant. Let's have a look at the questions then. I've got one comment saying, well done. I think that was about going to the House of Commons. And then I've got one lady just signing up for the Sharing Network now. The one-to-one coaching sessions, sorry, the mentoring, is that based on your main hospital? One of the questions of the delegates here.
Is the coaching based on your main, sorry, it dropped out a little bit there.
Sorry, basically, is it locally or is it nationally, I would say, if I translate that question correctly? So how do you get matched with your mentor?
Okay, so in terms of being matched with your coach, usually the matching process that we'll have is that we will be, as part of your application form, you outline some of the kind of key areas that you're liking to focus on, and then we will match you with the coach. It's usually done virtually, so in terms of nationally, you can be anywhere, so that's not a restraint at all. They're held virtually unless people decide between themselves and the coach, oh, we're actually in the same area, can we meet face to face? But they're generally virtual.
Okay. Okay. I think those were the questions. Thank you very much, Adjoa. We'll put the link in the chat for participants on the call to join. Yeah, thank you.
Brilliant.
Thank you for joining.
Get in touch if anybody has any questions. Thank you.
Thank you. Now I'm just going to check with the team to see if we've got David on the call.
Leo, so Leo was just. Is Leo
on the call?
Still?
Excellent.
Yeah.
Hi, Leo.
Hi there.
Are you happy to present via the phone system, Leo?
Yeah. Apologies to everyone. My trust has blocked me from logging on via the GoToWebinar system, so I'm joining by my phone. So if I'm a bit out of sync with the slides on the screen, then apologies in advance for that.
Okay, thanks, Leo. So Leo is here to present on sharing medicines data, and Leo is the digital lead pharmacist at Somerset NHS Foundation Trust and has been working in the digital medicine sector for the past 6 years. And during this time, he has contributed to the national agenda for the digital medicines, producing blueprints for the NHS futures, and led the deployment of ePMA across multiple PAS and multiple site organisations. And like we said, there's the questions tab. So if you want to have any questions during Leo's presentations, please add them into the box there, and we'll hopefully answer them either after the presentation or after the session itself. I'll hand over to you, Leo, now.
Lovely, thank you. So first slide, please. So just a bit of background and some acknowledgements first. For those of you that have been at Rewired or at the Better Meds Community Day, you will have seen some of these slides before. But I work at Somerset NHS Foundation Trust. We cover all primary care, so all secondary care prescribing in the county. We've had 2 mergers in the past 4 years, which has resulted in us having a multi-PAS, multiple electronic discharge system organisation. And yeah, it's been a joy to try and work through all the complications that go with getting those systems to talk to each other. Next slide, please. So I wanted to talk to you primarily about the vision that we've got here in Somerset, and that is to utilise digital technology in 3 key areas. The first is to improve patient care, be this through increased staff efficiency, releasing time to care for patients, or through enhanced safety functions in digital systems, such as eliminating transcription errors, or through use of clinical decision support. Secondly, we want to, as an organisation, move towards a model of care whereby we can utilise data to learn from current practice and improve care pathways and models of care based on this data. And finally, we want to be able to put all of that together and put the power of technology in patients' hands, empowering them in their own care needs. Next slide, please. So Somerset's a large area. If you just click through, you should be able to see all the different sites that we currently have our EPMA system live in. So we've got a large area covered, and the main vision that we've got is to have a single EPMA system across all of our sites to provide seamless care and to eliminate some of the errors that were associated with transfers of care from community hospitals to secondary care, vice versa, and also at the point of discharge from those areas as well. So our ePrescribing system covers all acute care, community hospitals, ED, paediatrics, ICU, and we're currently trying to get it in place for prescribing for our hospital at home patients. So we're covering the full gamut right up to the edge of our secondary care involvement. Next slide, please. So I'm going to try and cover some of the basic infrastructure we've got set up because it all sort of is key to joining up this data across the county. So if we click through, you should see that it highlights that we've got 3 separate PAS systems. And next click, we're joined together through an in-house patient master index. So as a patient gets registered in one system, the patient master index registers them in all the other systems. And as a result of this, we're able to provide one set of information through to our ePrescribing system. And then at the other end, if you just click through again, we've been able to integrate our EPMA system with our 2 separate EDS systems. And that integration allows us to seamlessly transition prescriptions from the current inpatient prescription into our discharge summaries, again, eliminating the transcription errors associated with moving data from one point to another. Next click, please. So we are currently integrated, with our CIDR record, which is what I'm going to talk about in a few minutes' time. This is developed through a FHIR aggregator, and this basically sends structured medication information that has been consumed from the GP records directly into our EPMA system. And final click, please. And ultimately, we end up with our single EPMA solution, and we are currently one of the first of type trusts looking at developing EPS for secondary care. So we're going to plan to utilise that for providing medication supplies for our hospital at home patients. And then next click shows you the whole infrastructure grouped together. So next slide, please. So all of this has been made possible through selecting the right EPMA system. We've selected one that is DMD native and that's based on open EHR standards. Next click. Utilising that and creating that centralised view of patients' records across Somerset through CIDR, and then utilising FHIR standards. Sorry, next click. To be able to work with suppliers to create interoperability between our systems that utilise medicine components. Next click. And then what's in the pipeline for our future? Well, we're looking to create a structured, consolidated record with a timeline so that all of the medicines information that is currently presented in our CIDR platform is aligned against a single sort of consolidated view, so we can readily and easily track changes that have happened to individual medications regardless of the care setting they're in. So instead of having to look at a discharge summary and look at a GP record and look at something that's happened in primary care for all different changes for a single prescription. It's all consolidated in one view. And ultimately, that will unlock new models of care for our patients across Somerset. Next slide. And what we've achieved so far is care continuity across primary care, interface into secondary care, and then through into our community hospitals. And eventually we'll be able to unlock those benefits back into primary care through EPS and further development. So next slide, I'm going to talk to you about our CIDR record. And click through. So what is CIDR? It's our Somerset Integrated Digital Electronic Record, not the alcoholic drink associated with Somerset. And it's a collated record of patient clinical information from Somerset services, as long as those services have signed up to use it. So it doesn't encompass all data, but it does encompass a large amount of it, and this is really useful for creating that sort of consolidated record. Next slide, please. So this is just a high-level view of the shared care records. So you can see here that you've got information populated from multiple sources. You've got your medication information, allergies data, recent encounters and procedures, and problems as well. And then across the top, you've got the different tabs. If you want to see information from specific areas, then you can look at those specific areas. So it's not just utilised by our pharmacy team for medicines information, it's also utilised by our therapies departments for other elements of care for our patients. Now, the next slide should hopefully be showing you a nice little GIF or GIF of how we've utilised CIDR's integration through interoperability directly into our EPMA system. So we're able to bring structured information through from the GP system, or from CIDR, sorry, and depending on the structure of that data, so how well it's aligned to interoperability standards for dose syntax, basically determines how much alteration our teams need to make. So where it's fully structured, we end up with the drug, dose, route, form, frequency, all pre-populated, and we can just click that straight across into our ePrescribing system's drug history. And for data that is semi-structured, we at least get the drug information, and we can populate the other fields manually ourselves. So we really are dependent on the source information providing data in a fully structured format. Next slide, please. So we identified some key areas for benefits realization. We worked alongside some pharmacy and digital colleagues in East Lancashire Hospital Trust to sort of get a baseline questionnaire set up. And then over the course of a week, we collected data on drug history accuracy, time to complete drug histories, and the number of pharmacy interventions made. And from the middle row on the slide here, you can see the estimation on the benefits that we can see having this integration with our CIDR record will provide. We are currently piloting it on a closed pilot at the moment, so I don't have any results for whether those benefits have been realised yet, but initial indicators are very positive. And then the bottom row of data here was obtained through observational studies on how long it takes prescribers to actually populate a discharge summary when they're not using interoperability, and then the number of errors associated with that process. So we took a large sample of discharge summaries, created and recalled patient notes to get that error rate. This is only looking at one of our trusts in an acute service, and obviously there are some caveats there in the top right-hand corner. So if anything, this is an underestimate of the amount of time and errors associated with use of medicines at the point of admission and at the point of discharge. So there's a huge scope for improvement through the use of interoperability. Next slide, please. The final thing I would just want to talk to you all about is just some of the challenges and considerations that we faced. So if we just click through here. Structured dose syntax, as I mentioned earlier, we're reliant on having structured data. The more our system can, the more source systems conform with the structured dose syntax interoperability standards, the better our integration works, and the more we can reduce transcription and transcription associated errors. We are reliant on having, with any interoperability, reliant on having our DMD codes aligned between systems, and therefore we need to definitely have backwards compatibility in any of the development work that's done in this area. And we also have to have processes in place to make sure that our clinical systems are kept up to date with DMD codes. And as we move forwards with other DMD reliance processes, such as barcoded medicines administration, this becomes even more important. And then we've faced some issues with API performance. So unsurprisingly, the GP records that we get fed through into CIDR has a large volume of data with it, and this can take some time to load. So what we are doing is working with our suppliers to start spinning up that service through at the point that the patient's brought into context, rather than the point that we start doing the drug history or the medicines reconciliation. And we're also developing a lazy load so that our clinicians can carry on doing other activities in the system whilst we wait for that data to generate. And then final point on this is just around data filtering. So some of the issues that we've had with the large volume of data, we're trying to address through filtering the data to only the last 12 months. We don't necessarily need to have data beyond that, as it's less likely to be clinically relevant. And if people do want to look back beyond 12 months of data, we can always load up the source system itself. And then one of the initial challenges we had was just around the quality of the data that we had. So we initially started with just having the medication statement information presented through from CIDR into our EPMA system. This didn't include some of the information around quantity supplied and issue dates, which is really useful, as people on this call will know, in the reconciliation process. So we're now moving towards a point where we can utilize the medication request in addition to the medication statements to get a greater wealth of data through into our system. And that is it from me. Any questions at all?
Hi, Leah. Thank you for that presentation. There was a question that we've had, and it's about, in order to facilitate the aggregated records, have you had to harmonise your EPR/EPMA across hospital sites, and are they all EMIS now?
So all of our GPs in Somerset utilise EMIS. So we've just got a single system feeding into the CIDR records, and we're in the process of deploying a single EPMA system across all of our sites in Somerset. So we're live in our large acute trust and in our community hospitals. We've got deployments into our second acute trust later this year, and then our mental health units after that. One of the difficulties we've got in Somerset is we border with Devon and with Dorset, so we do get a small percentage of patients coming across from county borders. So the benefits of having the CIDR record don't necessarily apply to those patients. We are working with the Dorset team to get integration with their Dorset Care record as well. So crossing borders there.
Okay, thank you, Leah. That was really interesting. Leah, are you happy if anyone does have any questions after the webinar for them to get in touch with you about the work that you were to do at Somerset?
Yeah, not a problem.
Thank you.
A massive thank you for all the speakers today. Leo, Sandeep, and Ajwa. Also, thank you all for tuning in into this masterclass. Apologies that we did have some technical issues, but we hope you enjoyed the session and have some takeaways to think about, basically. As mentioned before, certificates and recording will be sent out later today. On the slide here, the next session is on the 17th of July, and we've got Emma Kirk, Medication Safety Officer, coming to join us on that session. If you've got any ideas for future topics or feedback, or would like to come and present for us, please drop Sarah Black an email. Thank you for listening, and I hope you enjoyed the rest of the day.
Thank you, everyone.